All right, so just about 4:30, so I'm gonna get started here. Thanks everyone for joining. My name is Gabrielle Diulio. I'm a physical therapist and I work in the Merle's Inlet Clinic. And today we're gonna talk about total knee replacement and more specifically, just kind of what to expect both pre and post-op with physical therapy. And if you have any questions as we go through today, there's a little chat button on the bottom that feel free to kind of send any questions you have off, and I'll try my best to get to them as we go. All right, so we're going to start with a little bit of knee anatomy, just so we're all kind of on the same page as far as what we're talking about with the knee. So if you can see this picture here on the right side, pretty much the two main bones that make up your knee are your tibia from the bottom, and then you have your femur that comes up from the thigh. And in between, you have your meniscus here, both medial and lateral. You have your ACL and PCL in the middle, and then you have your patella, which is a floating bone, and that's your kneecap. And then you can also see you have a lot of muscle attachments on your knee. So your quad comes down and connects to it, 4 muscles that make up your quad, and they connect into your quadricep tendon, and you have your patellar tendon on the bottom. So all of those provide a lot of muscular and ligament support for your knee as well. So that's kind of a general look at the bony alignment, and then a little bit of the muscles that come involved with it too, and of a healthy knee.
Gabby?
Yes.
Can you hit share screen so we can see the actual pictures?
Oh, yes.
You're good.
I thought it did that. Okay, pause. Sorry about that. Is that better?
Perfect.
Okay.
Perfect.
Sorry about that. So now let's go back for that again. So on the side, now you can see your healthy knee where you have your tibia on the bottom, your femur on top, the meniscus in the middle, your ACL, PCL, and then your patella, which is your floating bone there. And then you can see that quad on the side part where all your muscles come down and attach, and your tendons that connect down to your patella. And overall, like I said, pretty much a healthy knee here, and just so everyone's kind of on the same page as far as what it's looking like. Now moving on to osteoarthritis. So in terms of like a knee replacement, this is, I would say, the main cause of what leads someone to have a knee replacement. So osteoarthritis is kind of a broad term that pretty much just means inflammation of the articular cartilage of your knee. So the articular cartilage lines the bones of the joints. So you kind of have 4 stages of it. And as you can see, going from stage 1 to 4, the articular cartilage little by little wears down. So in stage 1, you pretty much don't really have anything going on. Stage 2, you start to see some of that wear and tear going on in the knee. And stage 3, a little more, and then stage 4, more advanced. And it's a chronic condition, so not something that happens overnight or over the course of a couple of days. It happens over the span of more months to years, which is kind of why it's more of a chronic condition. And as you go through the stages, you have less and less of joint space. So through that loss of joint space, plus the loss of or inflammation of the articular cartilage, people tend to have pain. And that's probably the main thing that leads most people to go either to a doctor or someone else to get their knee checked out. In addition to pain, there can be complaints of stiffness of the knee, loss of range of motion of the knee, especially in the morning. If you wake up and you say, oh, like my knee's so stiff in the morning, but then I get moving and it doesn't feel quite as bad. So that can be a sign of that osteoarthritis as well. Also, sometimes instability is a big complaint as well. If you feel like you're walking and your knee might give out, or you might feel like it's slipping, or sometimes even catching. Sometimes that's a meniscus issue, or sometimes if it is in more of the advanced stage of arthritis, it can be a cause from that too. If it's not just from over time, sometimes if you're born with a different kind of bony alignment of your knee, whether you're born more bow-legged or more of kind of a knock-kneed position of your knees, those can lead to over time being more prone to wearing of the knee as well. And not much you can change about your bony alignment that you're born with. So that's just something that person to person may kind of come into play. And like I said, the 4 stages of it. So I'd say kind of when you get more towards definitely the stage 3, stage 4, that's when tend to have more of those pain and symptoms and lead to going to get checked out from typically a doctor. So when you go to see the doctor, what do? They try to help you with your pain, your instability, whatever you're having. So treatments kind of range from more conservative to more aggressive as time goes by. So they might recommend something as simple as cortisone injection, or sometimes a gel injection in the knee. Of course, activity modifications always helpful too. If you're doing certain things that are directly contributing to the pain, you might want to stop those. So if you're an avid walker, maybe switching to biking or swimming, something a little less impactful on the knee. Physical therapy is always an option as well, which we'll get more into depth as time goes on too. And we'll do some imaging as well, which is where they'll kind of get more of an idea of the grade of arthritis that you're at. So now getting into a knee replacement and what actually knee replacement is. So I'm sure everyone's heard of a knee replacement, either maybe had one before, know someone that's had one, or has heard stories about it. And it's kind of well known, I'd say, in overall as far as knee surgeries. So a knee replacement is a total knee arthroplasty, meaning they're pretty much going to resurface the arthritic joint that you have, so your knee. They're going to resurface it by removing the arthritic parts and replace them with a prosthesis. So this is a pretty good picture here that we have. On the left side, you can see the before picture where that articular cartilage is really, really worn down, and even kind of on the through the meniscus and all too, pretty worn down. And then the after picture where they have it resurfaced now with the metal, usually titanium. And nice spacer in the knee, so that joint space that we talked about is back into a little better position, and all those surfaces will move nice and easy against each other. I won't get really in depth about the actual surgical procedure. If you are curious about what they actually do in surgery, I'd say there's tons and tons of videos out there that can get a little bit graphic, so I'll spare everyone that. But big incision down the front of your knee, and do the surgery from there. Moving further with the knee replacement. So there's also an option of a partial knee replacement. So the one we just talked about beforehand was the full total knee replacement. You saw both compartments of the knee that were replaced. So a partial knee replacement is more of a rare case. So this is something that's not nearly as much common at all as the full knee replacement. And the partial knee replacement is if you just for some reason have that articular cartilage really worn down in either the medial or lateral side of your knee. So part of this can come into play if you have those bony alignment kind of issues from a younger age that may play a part of it. So if you're bow-legged or more knock-kneed and you had either the medial or lateral side more worn down, they can go in and your surgeon can go in and just kind of do more of a unilateral replacement here. So unilateral replacement, partial knee replacement, same thing. And this is it has some pros and cons. Definitely more of a rare case that someone only has one side worn down. But you can see here of a before picture where just the for this person here, it's their medial side that's really worn down, less joint space. Lateral side looks pretty good. And then after surgery, they go ahead and just have that that one side replaced. So it has some pros and cons. Pros, it's less invasive, so you still have an incision to get to your knee, of course, but little less invasive as far as the actual surgery goes. Typically less blood loss, typically less post-op pain, and overall typically a quicker recovery. So this kind of goes with this surgery as well as everything else I'll mention too. I'm just kind of talking about the typical recovery average. Of course, case by case, everyone is different, everyone progresses differently, and that's more of an individualized thing. But we'll just kind of cover the typical progress, what to expect pre and post-op. And then cons, of course, so everyone says, well, hey, this might be great, maybe I should just do this. So you have to be a candidate first of all, so you only have to have the one side that's pretty worn down to indicate the surgery. And then a con is that you might end up having to require further surgery later in life if your other side, the articular cartilage, wears down. So that's the decision between you and your surgeon, and they'll guide you in the best direction for you. So some pre-op considerations for the surgery. So I always say that it's a big surgery, and the more that you prepare yourself beforehand will tend to lead yourself to a better outcome afterwards. So before you even have the surgery, just things to think about. So you always want to prepare your home the best you can. So what does it mean by prepare your home? So you want to decrease any fall hazards, first of all. So any rugs that you have lying around, whether they're in the living room, the bathroom, if you don't need them, pick them up, get rid of them. Any furniture that you have that's unnecessary or just kind of in the way, just kind of move it to the side for the time being. You want to have a nice sturdy chair with arms that you're able to kind of push yourself off from, or if you're sitting, definitely the edge of the couch where you can use the side of the couch to help you stand up from. Grab bars are really helpful both in your shower and also by the toilet to help you get up from if you're able to install them or have them there. Raised toilet seats really helpful. And I'd say just in general, keeping in mind that you're going to be using a walker after the surgery, which we'll talk a little bit more about. So you kind of want to have enough space wherever you're walking through bedroom or living room that you can navigate with a walker through. So it'll take up typically a little bit more space than just you regularly walking. Also, having a caregiver is important as well. So whether it's someone that you're living with, a spouse, maybe a son, a daughter, or even a neighbor that can check in on you, and or even some friends that are local. So it's important to have at least one person you can call, especially that first week or two after the surgery, because it's a big surgery to undergo. If you need a first floor sleeping space, if you have a lot of steps to go up and down to get to your bedroom, that's something to think about too. Whether it's just a pull-out bed or if you have a spare bedroom on the first floor, if you typically sleep on the second, might be better to maybe use that in the beginning until you're a little bit stronger and moving better. And a shower chair is also helpful too, which this is a pretty good picture here showing the shower chair, some grab bars. It's a very safe home setup compared to no grab bars and just without a shower chair in there. Improving your strength, improving your range of motion pre-op is beneficial as well. The stronger and the more mobile you go into any surgery, you typically correlates to a quicker and better and smoother outcome afterwards. And we'll definitely talk a little bit more in respects to that as far as how physical therapy can help. Having a driver is very important after surgery. So after the surgery, especially if it's your right leg, you'll not be driving for several weeks. So you don't have the surgery and then pop up and feel great and you're driving yourself the next day. If you're on any kind of pain medication, that's to take into consideration. So again, having that caregiver that will be able to give you rides to and from therapy is important to have that set up. And ice. So ice packs is probably one of the most important things you can prepare yourself pre-op for. At least 2 ice packs, you can interchange them from the freezer, have them ready to go. Ice is going to feel great and be one of the best things you can do for yourself post-op. You also do want to try to remain as active as you can be. So with arthritis, activity in itself is not going to further damage your knee. Now, you also may have more pain the more you do. So it's kind of about finding that floating balance of just kind of doing what you can tolerate. So you don't want to stop doing any kind of movement before surgery, even if you're having a lot of pain or a lot of symptoms limiting you. But you don't want to do so much that you're constantly giving yourself more pain too. So just activity to tolerance, and that's what I would recommend pre-op. So how does physical therapy play a role in this? So with physical therapy, there's a few exercises that are beneficial pre-op. So very simple ones that if you've had therapy for your knee at all times, you may be familiar with. So a lot of them focus on quad strength, since that's one of your main muscle supporters of the knee, and it's also a muscle that's gets weak from trauma from surgery and from where the incisions have to be. So we'll go through a few of them here, and all very simple that you're able to do at home with minimal to no equipment needed. So the first exercise we have here, it's called a quad set, and you can see the model here is laying down, looks like on a table or on a bed or so, and all they're doing from here is actively contracting their quadriceps. So he's taking his knee and pushing it straight down into the table or bed. I usually recommend holding it for 5 to 10 seconds to get that muscle contraction and then relaxing. And by kind of repeating that over and over, that isometric motion, you're building a little bit of quad strength. The second one is called a short arc quad. And from there, you can bunch up a few towels like the picture shows, or even a pillow or so. Prop it underneath your knee. You have your starting position on top with the knee bent down, ending position where you're extending that knee up, and then slowly lowering it back down. You're also able to add some leg weights onto any of these exercises, or the ones that are appropriate like this one, and that'll help to give you further challenge if some of these start to get easy pre-op. Last one on this page is a straight leg raise. So from here, you'll be able to see the demonstrator here is kind of slowly, actively lifting his leg up in the air and lowering it back down. And that's another really good one to build some strength. All right, I'm gonna take a question quick that just came through. So the question is, if my mother's coming to OrthoSD to see you for rehab, can I come with her to learn the exercises with her to help her more at home? So the answer for that would be, right now, I would say broad answer is yes. So when you come in pre-op, we will be able to give you some pictures to follow and go through that. With COVID-19 right now, there's been a few restrictions on who's allowed to accompany someone in. But if it's more of a medically necessary thing that you would accompany her for in, then that should be fine. I don't see a reason why there would be a problem with that at all. And especially if it's something that's medically necessary for cueing and kind of helping out at home, there shouldn't be a problem with that at all. All right, so a few more good pre-op exercises. So next one's a little side lying hip abduction, which is pretty good to get that hip involved, and that hip plays a really large role in knee stability as well. So I always like to add a few of those in. And the last two here are more for knee motion. So some people are lacking knee motion before surgery, some people are not. If your motion's good, these aren't necessarily ones you'd have to do. And if it is, then these may be good for you. So this is kind of where that person-to-person case basis comes in. Everyone's a little bit different. So if this isn't something that you would be necessary to do if your motion's good, then you won't have to worry about it. But the middle one's a seated heel slide, so pretty comfortable position. You can sit in whatever comfortable chair you have at home. And as you can see, they're just kind of sliding their knee backwards, holding a little bit, and then releasing it again. And by little, stretching like that, you should be able to improve the bending part of your knee, which is called knee flexion. And the last exercise to work on knee extension. And pretty much just a knee extension stretch. So the gentleman has his leg propped up on a chair. You can also use an ottoman at home. And this is if you're not able to fully straighten your knee pre-op. And pretty easy way to do this is if you have a book bag or even like your purse or so, and it has a few straps on it. Even a grocery bag, you can put that. You see one strap below the knee, one strap on top of the knee. And I recommend putting in a few water bottles or something, maybe 3 to 5 pounds to start. You want to put that weight in there and then let your leg hang into that extension stretch for, I would say, 1 minute to 2 minutes to start. If that's too much, you may need to start at 30 seconds and gradually increase the weight as well to probably being able to hold it for about 4 or 5 minutes at a time and working your way up to 5 or even up to a little bit more pounds based on whatever you can tolerate. Now, post-op. So this is where the fun begins, and again, physical therapy plays a very large role. So post-op with physical therapy, it begins typically 0 to 1 days post-op. So that depends largely on where your surgery is taking place. So there's options now where you may have your surgery in a hospital, or there's outpatient surgery centers as well. So if you have your surgery done in an outpatient surgery center, you will be going home the same day. And that same day, you should see a physical therapist that'll come down. Make sure you have a few exercises that you're comfortable with starting until you start your next therapy appointment, and make sure that you're walking safely with your walker. Make sure it's a good height. If you have any steps at home they have to do, making sure that you have a good sequence of the steps as well. So that will be that 0 day if you have your surgery done in an outpatient surgery center. If you have your surgery done in a hospital, you may also start your therapy that same day, depending on the time of your surgery, or just how you're doing overall. If your blood pressure is good, if you're stable, to start getting up and walking a little bit. If you have it done in the hospital, you may go home that same day if you're doing very well, or based on how you're doing or time of day of surgery, you may end up spending 1 night, which is also normal to get you home. And then sometimes if there are a few complications, then you may end up spending an additional night. The stockings that you see in this picture, compression stockings, so those are very, very standard, regardless of your surgeon, especially with ortho SC that you'll see. You may, this is also a surgeon's preference, you may have either knee-high stockings or on the thigh-high stockings. And those are pretty standard. Those are worn, say, 23 out of 24 hours a day, pretty much just taking them off to shower initially for the first 2 weeks. And then from there, may end up being able to decrease the usage of them based on your swelling and overall how you're doing. Outpatient PT overall typically begins 1 to 3 days post-op. And again, this depends on where you had your surgery, if you're spending a night in the hospital, if you're spending 2 nights. Might even depend on the day of the week. So if you have your surgery on a Friday, you'll most likely start on a Monday with outpatient PT. So somewhere in that 1 to 3 day range, you're going to be starting outpatient PT, where we'll then be able to provide you with further exercise and just kind of guide you along the recovery. You'll be using a walker, like I mentioned before, post-op. So typically a rolling walker where you have the 2 wheels in the front and the 2 legs on the back. And you'll be able to kind of push that along, and that's used for support. And since your leg is weak, you're most likely going to be having pain post-op for safety and to decrease your fall risk. Ice and cold packs, extremely important post-op. So being able to ice that knee pretty consistently after surgery is going to feel good, help with swelling. So I'm just making sure you have those around. And the ice, as well as elevation, helps in management of swelling for your knee post-op. So swelling is very normal post-op. Everyone has some level of swelling. The picture on the right over here shows looks like a pretty new patient that just had surgery. It looks like they're still in their hospital gown. So this could be day of surgery, could be 1 day out. Yeah, a little bit of swelling that shows up on here. They also have what's called an Aquacell bandage. That's what this big bandage is. Looks like a big Band-Aid. Very, very standard, especially with the surgeons through ortho SC to be using. And that bandage there is waterproof, so you'll be able to shower with it on. You do not take it off until about 2 weeks after surgery, where you'll go for a follow-up appointment and have that removed. And that's protecting your incision from anything from the outside environment getting in. Another thing post-op that's very important is the positioning of your knee. So in order to prevent the knee from getting contractures in it, and that you're able to reach your range of motion goals post-op, positioning we always try to go over as well. And this may be talked about in the hospital too. Before you leave, you can have it done there. So main thing with positioning is you don't want to be in one position all day for a long amount of time, whether it's sitting in a chair or whether it's laying down. So I say every couple hours, get up and walk. You don't want your knee either bent all day or straight all day. However, with that being said, if you are either laying down or kind of elevating your leg, you want to maintain full knee extension. So we never say to put a pillow at all directly underneath your knee. That's very bad. It'll lead to, or can lead to having a knee flexion contracture. So we say leave a pillow underneath your entire leg or just underneath your heel to encourage that knee to lie as flat as possible. Now that doesn't mean that you have to stay like that constantly all day. I say, like I said, every definitely 2 hours you want to get up, walk. So then from there you can go ahead and sit in a chair for a little bit. And when you're sitting in that chair, you want to kind of encourage that knee to bend and have it be in a more flexed position. Now, post-op symptoms, what to expect. So everyone's like, what's going to feel like after? You know, how am I going to feel? What's it going to look like? This varies person to person a lot. So in general, you can expect pain. Everyone has pain to some level or another. Some people have more pain than others, but pain's inevitable. Typically, day of surgery, you feel pretty good, but from then on, you may start to have more pain that develops. Swelling, very, very normal. Everyone has different levels of swelling, but you can expect that from your thigh to your knee to your calf. Bruising, very, very normal. So the picture here shows a leg with a lot of bruising in it, and that's also normal. So it can be all throughout your thigh, the back of your leg, your calf, the back of your knee. And that's something that if you're concerned about it, you can always talk to your physical therapist about it too. And they've seen lots and lots of people post-op, and will be able to let you know if it's normal or maybe something that needs to get checked out. Stiffness in the knee is common as well. A lot of that has to do with the swelling. So stiffness is common, and kind of like I mentioned before, the best thing to do for that is just to every couple hours get up and walk, plus doing all the post-op exercises that we'll go through. Nausea, decreased appetite, constipation, all those kind of tie into play of if you're taking the narcotic pain medication post-op. So the narcotic pain medications is important because it helps you be able to function and do everything that you're able to do to the best of your ability, but also has some unfortunate side effects. So some of these are you may kind of run into some trouble with, but a lot of that's tied to the pain medication and just post-op pain too. Difficulty sleeping is a huge complaint, and there's no special week that just gets better. Sleeping, you may have some trouble for the first few nights only. Other people have trouble sleeping for up to a month or so. And that's something that just person to person will eventually get better. Those are some of the big complaints that I'd say people mostly complain about post-op. The thing to think about these two is that you may be experiencing all these symptoms post-op, but it's they're only temporary. So if you're kind of living with chronic knee pain right now and it's every single day not getting better, these are symptoms that even if you experience them for a week or 2 weeks or a month, week by week, they should be getting better and better and better. And eventually, once you fully heal, you won't be experiencing these. So this isn't a forever thing, just some things to be aware of post-op. Now, post-op goals. So this is something that, especially when you're in therapy, we really try to track for you. So I like to kind of break it up into a few shorter term goals and a few longer term goals. So at about 2 weeks post-op, I like to see people that have had a knee replacement with a range of motion 0 to 90 degrees. So this is around the time that you go to get that Aquacell bandage off from your doctor, and you'll get it replaced with these white steri strips on the front of your knee. And this patient actually has a few that probably have fell off already. So 0 to 90 degrees means full extension of your knee. So if you're lying, your knee is able to fully be flat on the bed or wherever you're lying, and then sitting comfortably at a 90-degree angle. And that full extension is important. It helps your gait form. And at this point, hopefully also progressing from a walker to a cane, at least for short distances, maybe just in the house. So those are some great goals to hit 2 weeks. Now, everyone's not there at 2 weeks, which is fine, but hopefully at least making progress towards these short-term goals around 2 weeks and definitely by 3 weeks. All right, I'm going to take another question quick. So the question is, if the gel pad in the picture comes off, should I call the doctor or let you know? So I'm guessing you're talking about the Aquacell bandage. And so this bandage really shouldn't come off post-op, but so definitely you don't want to take it off yourself. If it starts to peel at the edges, we may be able to provide you with some skin-sensitive, skin-appropriate tape to put down on it to just kind of hold it down until you get to that 2 week point where it can come off. If for some reason that's still not working and it's really coming off, if you're going to physical therapy, your therapist should be able to direct you along what you should be doing for it. So whether it's just putting another replacement Aquacell bandage on until you can get to that 2 week follow-up with the doctor, or if it's looking like it may be something that needs to get checked out with them, then I'm just referring you to the doctor. but it's definitely something that you don't want to take off on your own. You want to try to leave it on as long as you can, and if anything, just kind of put a little tape over it to keep it down. So a few long-term goals also that are important as well to meet. So again, with the knee range of motion, that maintain that full extension, and then 120 degrees is kind of the goal number to hit with flexion or greater. I don't want to limit you to 120 degrees, but those are kind of the standard set full range of motion measurements after a knee replacement of your knee. You also want to have adequate strength regains in order to perform all your necessary just tasks, hobbies, things you want to do every day. So this varies greatly person to person. Some people really just after a knee replacement want to be able to walk pain-free around their house and go for leisurely walks and just do more house and a little bit low-level activity, which is fine. Other people may have to return to work where they're going up and down steps all day, or doing a little bit maybe higher level things. So this is something that adequate strength is something that's just between you and your therapist, and they'll be able to kind of get you back to what you need to do post-op. Also, before discharge from therapy, another long-term goal is really ambulation, so walking without any assisted device. So no cane, no walker, not using any of those to help you, and be able to do all that safely without being at a fall risk. So I do want to talk a little bit more about range of motion. This is a huge thing that physical therapists and myself we look at with the knee replacement, especially post-op. So this picture on the left here is a really nice picture of kind of what different motion measurements look like. So a full extension is with the leg and knee fully extended there. That's called 0 degrees. And as you can see, you get to that 90-degree mark, and it's about a 90-degree angle, or it is a 90-degree angle that you're sitting at. So in order to safely ascend stairs or go upstairs, you need about 83 degrees of motion. And this varies a little bit on kind of what you're referencing, but somewhere in that 80-85 degree mark of knee flexion, you're able to safely, reciprocally go upstairs. In order to go downstairs, you need more around 105 degrees. So going up steps is going to come easier than going down steps. In order to get up from a chair, you need a little bit more past that 90 degrees of motion as well. So about that 105, and I guess descending steps maybe closer to that 90-degree mark, but somewhere in that range. Really, once you hit 90 degrees, everything from there starts to get easier. That's kind of your big mark to get to. So you think about it, when you kind of get up from a chair, you normally don't keep your knees flat at 90 degrees. You usually bring them back a little bit underneath the chair in order to help yourself push up. So you get that leverage from there. In order to ride a bike, and this isn't a recumbent bike that you are able to kind of sit back and be comfortable, and this is more that you want to take around your neighborhood or so. 115 degrees is around about range of motion mark to get to be able to do that safely and feel comfortable with. And full flexion, I'd say, of the knee is 135 in general. With the knee replacement, you may not get 135, which most people don't. So even riding a bike 115 degrees, if you're able to get to 120, 125, you should not be limited with anything you need to do. Just like the kind of picture on the right over here shows, you can garden, you can squat, you can do all these things you want to do with around that 120 degree mark. Also, just kind of this first activity on here, whereas walking without a limp, so you only need 70 degrees of knee motion to walk regularly. And if you think about it, you don't really take high steps or march or doing these large motions at your legs when you're walking. So in order to walk regularly with that normal gait pattern, you don't need a lot of knee motion. So initially we do try to stress getting that normal pattern back, and try not to guard the motion, because motion doesn't really play a large role with that. Once you get to that 70 degrees of motion mark, at that point it's more pain that may be limiting you. So just kind of keep that in mind. So a knee manipulation, this is something that you also may have heard of, and this is something that if you don't end up getting to these set knee range of motion marks, so especially if you're not getting to 90 degrees, that's an issue. at a certain point post-op. And if you're not getting up towards at least 100, 105, depending on what you desire to do with your daily goals and what we have to get you back to doing, this may be something that's suggested by your surgeon or by the PA that's following up with you. And this is something that can sound scary, but it's not invasive like the surgery is. There's no incisions being made, there's no cuts being made, but it is a procedure that's performed under anesthesia. So you'll end up going back in the operating room and kind of just like this picture shows, there's actually a pretty good picture. You'll have your surgeon that grabs the knee at the closest they can get up to the knee joint, and then moves that knee as much range as they're able to move it through. And this can be performed for either a flexion limitation, which is bending your knee, or extension if you're not able to get that knee all the way straight. And this can be if your body has for some reason formed excess scar tissue quicker than average, or if there's some other barrier that's limiting your motion. So once they're able to kind of push that knee through all the motion that you should be getting post-op, then again, physical therapy plays a large role in getting that motion back after the manipulation and maintaining it too. So a few post-op exercises here, and some of these will be similar to a few pre-op exercises, and some are different. So again, this will vary a little bit person by person based on your goals, but I'd say very, very early on, the first week or so of surgery is pretty standard for the most part across the board for every patient. So again, the quad set's a huge exercise to perform afterwards. Very, very simple one to do. But you can kind of notice now that instead of having the leg out flat like the picture before showed, post-op, we really want to achieve that extension of the knee. So there's a towel underneath the heel for this. So if you're able to tolerate that based on pain, we're trying to really get that extension with it too, where you're performing the motion. Or if you can't, definitely with just the leg flat on the table. You don't want to put anything right underneath that knee like we mentioned. A long arc quad is just a sitting knee kick with your leg, sitting in a chair and fully extending the leg, again, to work on that quad strength. And the last exercise on here on this slide is a heel slide. So this is one that's very important in helping the motion come along at the knee. And you can do this at home with a towel or a belt or anything that's not going to be stretchable on you, and lying right in bed, hooking it around your foot, and then using that to assist in bending your knee. Some other good post-op exercises, a few of them here are in weight-bearing position, which I always like to kind of help patients get into as quick as possible, because it's going to make you feel comfortable with both feet on the floor, getting that pretty equal weight-bearing stance leg to leg, ideally 50-50 with your legs, kind of helping facilitate getting back that normal gait pattern and getting you comfortable with putting weight through the legs. So the one on the left is a simple heel raise or a calf raise where you're going up and down your toes. This can be performed with either a chair supporting you or even just using your walker, which I think is probably the safest and easiest place to do it. And then you also have a hamstring curl in the middle here, where you're just actively trying to do kind of like a butt kick motion. You're trying to bring your heel up towards your bottom and then back down. And the last one, just an isometric ball squeeze, a hip adduction, and where you're kind of isometrically contracting your inner thighs by squeezing into a ball or a pillow. Healing of the knee. So full healing can take up to a year from surgery. It's not to say that you're going to be in therapy for a year, but full healing internally usually takes anywhere from, I'd say, even 9 months to a year is a good amount of healing for, or good time for healing to occur. So beforehand, you can kind of see the, again, that joint space that's narrowed on the knee here. And then afterwards, this is what an x-ray of your prosthesis will look like, where you have the components on either side of the knee and how they're giving you that joint space again, and everything looks in good alignment here with this image. Here you'll have your incision on the outside, and this one's healing very nicely. It's about the size the incision will look like. And as it goes through its healing process, it'll kind of get from a more red to more of a pinkish color, slowly fading and fading to more of a whitish silver color, blending into your skin as it heals more and more and more. And throughout this whole, I'd say 9 months to a year process of full healing, everyone has some level of fluctuating symptoms that can continue through the whole time frame. So some people's pain lasts a little bit longer through those first few weeks than others. Some people, like I said, maybe have trouble sleeping longer than others. Some people have swelling longer than others. But as long as you're continually healing more and more and more, your function's getting better, that's exactly what we're looking for. So now, when can I return to whatever it is that you want to do? And this is kind of an average amount of some of these tasks. And this, again, varies person to person. So driving. This is going to depend on a few factors. First of all, what leg you're having operated on. So if it's your right leg, which is your driving leg, typically a little bit on the longer scale of these things. If it's more of your left leg where you're not really needing it to drive at all, you may be on the shorter end. Driving is limited by if you're taking the narcotic pain medication. If you are, you can't be driving. We want to wait until you're off that to be driving. Once you can get off that, and I'd say if you're at least getting down to a cane, if not no assisted device, and then kind of your overall strength and function. So that's something you can definitely talk to your therapist about, your physical therapist, and they'll be able to guide you along those. But I'd say typically a minimum of about 3 weeks if you're doing great, that I would recommend not driving, up to about 6 weeks based on a person-to-person case. Pool activities, so even just kind of getting in a pool, especially in the summertime, people are very anxious to get back in a pool or just kind of relax. For this, we want to take into account the incision healing. So once your incision is healed to the point where there's no scabbing, everything's fully closed on the incision, you're able to get back in the water. So again, person to person basis, and again, talk to your therapist about it. I'd say average 4 to 6 weeks. Person to person, maybe a little bit more depending on your healing time. Outdoor biking, so getting back to your bike, riding around the neighborhood. This depends on your knee motion for the most part and just safety getting on and off it. So somewhere in that 6 to 8 week time frame, you should be hitting that 115 degree mark of knee flexion, ideally, unless you're lagging behind for some reason, you can get back to biking. Yard work, so mowing the lawn, weeding, gardening, doing whatever you want to do kind of around your yard. I'd say 4 to 8 weeks, kind of depending on how quick you heal and based on how you do overall. Golfing, average of about 6 weeks. And work, this is just so variable. I'm not even going to put a time frame on it. Totally depends on what you do for work, what your occupation is. So if you're having a job that's more involved, I would say, then you'll probably be a little longer on the scale towards getting back to work. If you're having something that's more of a desk job, you may be back to work in even 6 weeks time or so. Let me go back a second. All right. Now there are a few restrictions after surgery that I do want to mention. So after the knee surgery, we don't recommend at all getting back to running, just because it's a very impactful activity on your knee. So anything running, jumping, sports like basketball where you're jumping up and down, things like that, you kind of want to avoid any of that. And more low impact things like swimming, biking, walking, all of those are fine to get back to. So again, sports like basketball, skiing, snowboarding, things that are a lot more aggressive on the knee, typically don't recommend getting back to. But again, case by case basis, but for the most part, I would avoid those. You kind of want to avoid also weighted deep squats. So especially if you have a lot of weight on a bar and you're trying to go down into a deep squat, probably not the best idea. So squatting is going to be fine after surgery once you get healed to a certain point, but I will go very light on weights and kind of keeping it more of a mini squat motion rather than a deep squat. Again, just to avoid excess strain on the knee. And kneeling, so this is something that I'm not going to say you have a restriction on after surgery, but you don't want to do it until your incision's fully healed in the front. So you kind of want to wait till I would say scabbing's all gone, your incision's fully healed. And also the skin's a little bit more together there, just so you don't end up having that skin dehisce, which is also where it pulls apart a little bit and can bleed. So we want to avoid all that. So once you're fully healed, you'll be fine to get back to kneeling if you have to do it for a short amount of time, like just picking something off the floor quick, or getting on your hands and knees to reach something that you dropped into the couch. But it's something that most likely will always be uncomfortable. So I wouldn't recommend trying to do it on a regular basis. And if you do have to do it for any reason, like gardening or so for a short amount of time, I would recommend getting a foam pad or so to kneel on, just to make it a little bit more comfortable. And then full healing. So these are all things that you'll get back to doing, and ideally pain-free and without limitation after going through the whole process of the surgery and rehab and all. So golfing, biking on the beach or your neighborhood, playing with your children, neighbors, grandchildren, without being limited by pain or instability everywhere, or fishing, or enjoying any of your hobbies that you like to do. And that's our goal with therapy, is really just to get back to doing whatever you desire to do. And that's about it. So if you have any questions, I'll stay on a couple minutes here. Just send your questions away, and I'll do my best to get into answering them. But yeah, that's about it. Hopefully it was informative for everyone.
Gabby, it looks like there's one more question.
Okay. Okay, so I see this here. Okay, so this is really good to hear. It says, this is not a question, but after my surgery and PT, this person was able to get back to playing golf quickly, and says their game has gotten better because their knee doesn't hurt, and they say thank you. So that's always really, really good to hear. And that's kind of what we do, and just to get you back to living the life you want to live without as much limitation. So thank you to whoever sent this, and that's really good to hear.
Gabby, thank you for the presentation. I think that's all the questions.
Okay. All right. Thank you, everyone.